Welcome to this CME educational program about using JAK inhibitors in myelofibrosis care, the evidence, timing, and strategic approaches. So my name is Aaron Gertz. I'm an associate professor of medicine at the Cleveland Clinic, and I also serve as the deputy director for clinical research at the Taussig Cancer Institute. It's my pleasure to be with you today to discuss myelofibrosis. So our first learning objective is to assess patients for myelofibrosis therapy using guideline-recommended risk stratification algorithms, as well as molecular indicators of disease, prognosis, clinical features, and symptom burden. Myelofibrosis, whether it's overt or prefibrotic or early stage, sits within the myeloproliferative neoplasm category, which also includes polycythemia vera and essential thrombocythemia, two very closely related diseases. The diagnostic criteria for prefibrotic primary myelofibrosis really focuses on the grade of scar tissue. If you look at major criteria number 1, the fibrosis grade has to be less than 2. So you do have these typical features of myeloproliferation, but not a lot of scar tissue. You can still see other features of disease like elevated white blood cell count and palpable splenomegaly, but again, lacking that definite scar tissue in the bone marrow. A key piece of whether we're diagnosing prefibrotic primary myelofibrosis or overt myelofibrosis is identifying a driver mutation that drives JAK-STAT signaling. And those mutations occur in JAK2, calreticulin, or MPL, and we can see that here in major criterion number 3. And again, for overt myelofibrosis, we're really looking to see fibrosis that is either grade 2 or grade 3. And that really, again, distinguishes prefibrotic from overt fibrotic myelofibrosis. And the reason that this prefibrotic category was included in this diagnostic kind of continuum was the fact that we were missing a lot of patients who didn't quite meet the criteria for essential thrombocythemia and didn't quite meet the criteria for overt myelofibrosis. And so we're losing a whole category of patients. And so this change was made to address that. So myelofibrosis is really, it's a symptoms and needs-based approach. And so we really have to take a step back and think about what's going on with any individual patient before we start applying therapy. And of course, if the treatment goal is to alleviate symptoms, we think about reducing the total symptom score. We think about things like JAK inhibitors that can do that. In some patients, we see enlarged spleens. And so that can be a goal for some patients' therapy, especially if their spleens are impairing their ability to eat or leading to weight loss. Patients can have dysregulated hematopoiesis as well, leading to anemia and thrombocytopenia. And so strategies are needed in order to mitigate the risks that come with anemia and thrombocytopenia. The range of symptoms that we see in these patients is quite broad. So we think about them in a couple of different domains. So we sometimes think about cytokine-mediated symptoms like fevers and fatigue and night sweats, as well as spleen-related symptoms such as early satiety and weight loss. But there is a broad range of symptoms that do occur due to this disease, and really kind of taking a comprehensive inventory of one's symptoms that may or may not be related to their myelofibrosis is really important, not only at initial consultation, but at every visit thereafter. Myelofibrosis really takes a toll physically and emotionally. So physically, we've talked about anemia already and thrombocytopenia and splenomegaly and some of the other symptoms, but the fact that an individual has a chronic cancer, a chronic disease that will be with them for years unless they get a transplant, and that can potentially worsen over time is really something that can weigh on someone heavily. And then you start to see this interface of emotions and symptoms really kind of colliding in any given individual patient, and can really present a lot of barriers to treatment. So kind of getting back to the disease biology, at the central core of what we think about in MPNs is really constitutive JAK-STAT activation. And that's a result of either a mutation in JAK2, calreticulin, or CalR, and MPL, which is the gene that encodes the thrombopoietin receptor. In patients with polycythemia vera, it's almost entirely JAK2 V617F mutations that we see driving disease. In ET and myelofibrosis, we often see a little over half the patients have JAK2 V617F mutations, and roughly a quarter to a third will have CalR mutations, with the remainder being made up of MPL or other mutations. It doesn't matter if a patient has a JAK2, calreticulin, or MPL mutation. It all does the same thing downstream: activation constitutive activation of the JAK-STAT pathway. That's why JAK inhibitors that block wild-type JAK2 are effective no matter what the driver mutation is, because again, common pathway for all of these mutations. So really identifying this mutation, one, is very important for diagnosis. Two, is also important for understanding the biology and delivering therapies as well. But these aren't the only mutations that occur in disease. We know that this is a molecularly complex disease. Even if we look at essential thrombocythemia and polycythemia vera, there is a sizable number of patients that have more than the driver mutation present in their disease. And of course, as the disease progresses over time, we're more likely to see more and more mutations. Some of these mutations are associated with an adverse outcome. There are the typical ones we think about in any type of cancer, such as P53. Whenever we see TP53 mutations, that's always portends a poor risk. And some of these other mutations look very familiar because they are poor risk mutations seen in other myeloid malignancies, such as myelodysplastic syndromes and acute leukemias. And these can be very powerful at determining one's disease potential over time and risk for progression. Thus, that they've been incorporated into prognostic models. Now, we do have a lot of prognostic models in myelofibrosis. There's the MIPS score, which is molecularly driven. There's the DIPS score, which is a dynamic score, as well as the MySEC-PM, which is specific for patients who have post-PV and post-ET myelofibrosis. And really, the model that you choose is based on the information that you have. If you have basic clinical information, you can calculate a DIPS score. If you do have genetic information, a full NGS panel where we've looked at a multitude of genes potentially mutated in this disease, you can calculate a MIPS score. But at the end of the day, no matter which risk model you use, patients are classified into lower risk disease versus higher risk disease. Lower risk disease is typically, we think of patients who have a median survival or predicted median survival of greater than 5 years. Higher risk is those who have a median survival of less than 5 years. And this is really important for identifying patients who would be good candidates from a disease perspective for an allogeneic transplant. And so higher risk patients, we know that transplant outperforms non-transplant therapies. And in those patients, we would consider transplant earlier rather than later. However, in lower risk disease, the time horizon for progression is so long that we typically reserve transplant in those patients. Here's an example of one of those models. This is the Mutation Enhanced International Prognostic Scoring System. Again, where we take clinical variables and add in those molecular markers to better refine prognosis. And as in other models, we do see a nice splaying of the risk categories. So once you add up the points, disease is either identified as low, intermediate, or high risk, with corresponding 5-year overall survivals of 96, 67, and 34%, respectively. So learning objective number 2. Integrate current and emerging data on JAK inhibitors when choosing the most suitable myelofibrosis treatment for each individual patient. The history of MPNs is long. So if we look all the way back to 1879, HUAC described the first cases of myelofibrosis. And then 72 years later, Demeshek made a really insightful postulation that MPNs in general, ET, PV, myelofibrosis, were all very similar with similar clinical features, and there must be some sort of unifying pathologic feature amongst them all. And it was not until 2004 when JAK2 mutations were discovered in MPNs. And then 60 years after Demeshek's editorial, ruxolitinib, the first JAK inhibitor for the treatment of MPNs, was finally FDA approved. And we can see subsequent to this, just this explosion of activity in the field. But really a couple of watershed moments centering around first Demeshek's editorial and then the discovery of recurrent JAK2 mutations. But now we have 4 FDA-approved JAK inhibitors to treat myelofibrosis. And taking a look at this table, the one thing that connects them all is the fact that they all inhibit wild-type JAK2. Ruxolitinib, fedratinib, pacritinib, and momelotinib are all wild-type JAK2 inhibitors. And that's kind of the point where we line all these up. But the other things that they do helps us, one, to identify the population in which they may be most effective, and two, really help us better understand some of the side effects that we do observe in these patients who are taking these medications. So ruxolitinib was the first one approved. It was based on the COMFORT-1 and COMFORT-2 trials. It was approved in 2011 for intermediate and high-risk myelofibrosis independent of line because it was the only drug at the time. It is primarily a JAK1 and JAK2 inhibitor. As a result of the JAK1 and JAK2 inhibition, we do see anemia and thrombocytopenia as common side effects. There's also an increased risk for non-melanoma skin cancers and precancerous skin lesions. as well as high cholesterol and weight gain due to elevated leptin levels. Infections really center on viral reactivations such as shingles and reactivations of hepatitis viruses that were previously undiagnosed, as well as some case reports of reactivation of tuberculosis. So in any patients who have risk factors for those diseases should be screened before starting a JAK inhibitor. Fedratinib is mostly a JAK2 sparing JAK1, but FLT3 inhibitor. And it was approved based largely on the Jakarta and Jakarta-2 trials, with the subsequent Freedom study being completed after the approval in 2019. It's approved for the frontline or second-line treatment of intermediate to and high-risk myelofibrosis. Its major side effects really are cytopenias, not unlike ruxolitinib. But the major challenge with delivering therapy with fedratinib is really the GI toxicity. Being a FLT3 inhibitor, we do see significant rates of nausea and diarrhea that need to be preemptively treated before starting therapy. There is a concern over Wernicke's encephalopathy. There were a few cases reported in the initial studies with fedratinib, and upon further review, one was certainly confirmed to be Wernicke's encephalopathy. It was in a patient who was quite malnourished before starting therapy with fedratinib, but once the thiamine was replaced, the Wernicke's encephalopathy reversed. Nonetheless, there is a black box warning for checking thiamine levels before and during therapy. Most of us just have our patients take over-the-counter thiamine supplements just to make sure we're minimizing any risk there. Pacritinib is also a JAK2 inhibitor that spares JAK1, but it also has off-target effects, most notably on ACVR1, IRAK1, and FLT3. Again, being a FLT3 inhibitor, we do see GI toxicity. And given the patients' populations that was studied in the PERSIST-2 trial, namely thrombocytopenic patients, we can see hemorrhage and thrombocytopenia in this population. But somewhat unclear, is it really being driven by the JAK inhibition, or is it just innate thrombocytopenia due to the population? One thing that does need to be monitored while during the treatment with pacritinib is the QT interval. This drug can prolong QT intervals. It is approved and was approved in 2022 for the frontline treatment as well as subsequent line treatment of intermediate and high-risk myelofibrosis with patients with platelet counts less than 50,000. And a special note for the NCCN is it can be used in any second-line treatment with any platelet count. And that's really based, again, largely on both PERSIST-2 as well as the data from PAC 203, which was a large randomized phase 2 trial. But really, I think in everyday practice, pacritinib is thought of as a drug that can work in thrombocytopenic patients, namely myelofibrosis that kind of reaches towards the spectrum of myelodysplastic syndromes. And that's really interesting because it is an IRAK1 inhibitor, and we know IRAK1 is key in the pathobiology of myelodysplastic syndromes. In fact, there are IRAK inhibitors being developed right now for the treatment of myelodysplastic syndromes. So it begins to formulate where this drug might be successful in your mind and when using it every day in practice. Momelotinib was the fourth JAK inhibitor FDA approved. It was approved in 2023, based largely on the Simplify and Momentum studies. Momelotinib is a JAK1, JAK2 inhibitor similar to ruxolitinib, but also has this off-target effect on ACVR1, just like pacritinib does. And really, ACVR1 is thought to be the mechanism why patients' anemia improves on both momelotinib and pacritinib. ACVR1 is upstream of the gene that encodes hepcidin. Hepcidin is elevated in patients with myelofibrosis, leading to an anemia and inflammatory block. So by bringing down hepcidin levels, iron becomes available for erythropoiesis, thus alleviating that anemia of inflammatory block. In momelotinib, we do observe GI toxicity, not to the degree that we see with fedratinib and pacritinib, but certainly something to counsel your patients on when starting therapy. And being a JAK1, JAK2 inhibitor, we also do see evidence of cytopenias, namely thrombocytopenia, as well as some anemia. It was approved for intermediate or high-risk myelofibrosis with patients who have also concurrent anemia. And the NCCN right now rates it as a category 2B for that population. So to kind of start illustrating the points made with each of the different JAK inhibitors on the previous slide, we're gonna go over a case. So this case is JJ, who is a 58-year-old male with a newly diagnosed primary myelofibrosis. He presents with some constitutional symptoms, including fatigue, significant weight loss, and abdominal discomfort due to splenomegaly. He reports early satiety and a noticeable increase in abdominal girth. So clearly with this stem, we see that this patient is symptomatic. And so thus it is reasonable to initiate therapy independent of disease risk. Now, disease risk is very important to calculate. one, to counsel patients, but two, again, to identify patients where we may consider transplant referral earlier rather than later. This patient did have a bone marrow biopsy, which showed megakaryocytic proliferation and atypia, as well as grade 2 fibrosis. On the mutation testing, we saw the JAK2 V617F mutation, and thus, since they are almost mutually exclusive, we did not see a calreticulin mutation. Labs here are shown. The hemoglobin was 12, white count was 22, and the platelets were 108, with a couple of circulating blasts. So if we calculate, we do the old online calculator for the MIPS 70 score, comes out as a score of 3, which is an intermediate risk disease. And we can see here on the right-hand side of this slide, kind of the breakdown of each of the points that contributes to disease risk here. So again, circulating blasts, not having the calreticulin type mutation, no high-risk mutations, thus lands us in that intermediate risk category. So this patient started on ruxolitinib, which I think is a very appropriate choice. It is a very effective medication to treat symptoms and splenomegaly. In this patient, I would certainly be a little cautious given the platelet count is 108. And for some trials, we may start out at a lower dose. Certainly, there is some controversy within the field on a most appropriate starting dose. But what is clear is that over the course of early treatment, the goal is to maximize that dose, whether you're starting out at a high dose and working your way down based on side effects, or starting at a low dose, working your way up. That low dose ruxolitinib is less effective than high dose ruxolitinib. All right, ruxolitinib was approved based on the COMFORT studies, as mentioned earlier. COMFORT 1 was a randomized controlled trial in patients with platelet counts over 100,000 versus placebo. COMFORT 2 was the same population of patients, only versus best available therapy. In both studies, we saw large numbers of patients have an SVR35, that is a spleen volume reduction of at least 35%. In COMFORT 1, we see nearly half the patients have their symptom burden cut in half, and very few patients had to discontinue due to adverse events, although there were significant rates of anemia, thrombocytopenia, neutropenia, and fatigue observed in both of these studies. So ruxolitinib is a fantastic drug. It shrinks spleens. It makes people feel better. Even in a pooled analysis, there was suggestion that patients can live longer when randomized to ruxolitinib versus the control arms, but it does have limitations. In the COMFORT studies, the median duration of therapy was a little over 3 years. In real-world analysis, we can sometimes see those median durations of therapy even shorter. And some analyses will point to median durations of therapy as short as 5.5 months. And we know that when ruxolitinib duration is short, so is survival. Also, when spleens aren't being shrunk and symptoms aren't being improved, survival is shortened. So there are clearly some limitations to ruxolitinib. And not only through disease kind of persisting through JAK inhibitor therapy, but also, again, the limitation of the dosing due to cytopenias. Once ruxolitinib is discontinued, for whatever reason, whether it's due to lack of efficacy or side effects or cytopenias, survival is poor and is akin to the most highest risk disease, to the point where in patients who do not do well on ruxolitinib, who are otherwise good transplant candidates, we are considering referral to transplant at that point. A really handy-dandy tool that I like to use in my mind, at least conceptually when I'm in clinic, is this RR6 model. And there is an online calculator where you can go on and plug all the factors in and it will spit out the data for you. But this RR6 model really looked at a couple of different factors, both of the 3-month point and the 6-month point after initiating therapy. And really says that, if your patient is on a dose less than 20 milligrams twice daily, is getting transfusions, or their spleen hasn't shrunk, that they are not getting optimal therapy here. And with the advent of new JAK inhibitors, this is really important to look at, because if they're not being optimally managed, there are other options that are commercially available. Several years ago, when ruxolitinib was the only thing, we would stretch, we would push, we would try to keep using it as much as we can because that's all we had. But again, now there are 3 other JAK inhibitors approved. So if we're not hitting these metrics at the 3 and 6 month mark, alternative therapies need to be considered. So enter fedratinib, the second JAK inhibitor approved for the treatment of myelofibrosis. This is based largely on the JAKARTA and JAKARTA 2 trials. JAKARTA was an upfront study done in patients with platelet counts greater than 50,000, comparing 2 different doses of fedratinib versus placebo in higher risk patients. And similar to ruxolitinib, we saw significant numbers of patients with SVR35s and TSS50s, cutting their symptoms in half. There was higher rates of discontinuing due to adverse events, including not only cytopenias, but GI toxicity. To me, the most compelling data here is actually the Jakarta-2 data. And these were patients who were previously treated with ruxolitinib, then went on to fedratinib. And you could make a rational argument that since a patient received a JAK inhibitor, giving them a different JAK inhibitor wouldn't work. We've already exhausted that pathway. But here at Jakarta-2, even with a stringent reanalysis done in 2019, we still see significant numbers of patients having SVR35 and TSS50. Teaching us, one, that certainly fedratinib can be used in the second-line setting, but also that rotating through JAK inhibitors, although from a certain perspective may be illogical, actually in everyday practice can be beneficial for patients. And similar to ruxolitinib, we do see significant rates of anemia and thrombocytopenia, as well as some lymphopenia. But again, also the GI toxicity can be somewhat limiting with fedratinib. And as I mentioned earlier, there is the black box warning for Wernicke's encephalopathy with this medication. All right, to continue to illustrate the points about the different JAK inhibitors, we're going to return to our case now. So this is the same case as before. A 58-year-old male with newly diagnosed primary myelofibrosis, same bone marrow biopsy findings, same mutation analysis, but now instead of being 108, the platelets are 40. So this patient presents with thrombocytopenia, which is not that uncommon. Upwards of a quarter of patients will present with some degree of moderate to severe thrombocytopenia. So this changes two things. Of course, it changes the risk by the MIPS score. So we can see here that platelets less than 100,000 gets us 2 extra points, thus bumping him up into the high risk category. But two, if we look at the prescribing information for ruxolitinib, there is no guidance on how to dose ruxolitinib when platelets are less than 50,000. And there is a label indication now to use pacritinib, as well as endorsement from guidelines. So pacritinib was approved based largely on the PERSIST-2 trial and followed up by the PAC-203 study. PERSIST-2 was a prospective randomized trial comparing 2 different doses of pacritinib, 400 and 200 twice daily, 400 once daily and 200 twice daily. So the total daily dose, but just divided versus once daily, versus best available therapy. And the best available therapy turns out most of the time was in fact low-dose ruxolitinib, because largely these patients were thrombocytopenic. In fact, patients had to have a platelet count less than 100,000 in order to enroll on the study. So it was a mishmash of treatment lines. It was some patients who had previously untreated disease and some of those who had received prior JAK inhibitor. When looking at the 2 different dosings of pacritinib, the efficacy was quite similar, but maybe a little bit better numerically for pacritinib, 200 milligrams twice daily. But what was clear was that the side effect rates and AEs due to discontinuation were much fewer when pacritinib was broken down to 200 milligrams twice daily. So that was the dose taken forward for both future studies as well as on the label indication and prescribing information. And again, compared to best available therapy, which was largely low-dose ruxolitinib, it fared much better in shrinking spleens and improving symptoms. And again, on top of this, ruxolitinib was the only other JAK inhibitor approved at the time, and there was no guidance on how to dose ruxolitinib in these types of patients who had platelet counts less than 50,000. The most common side effects observed were anemia, thrombocytopenia, neutropenia. But again, being a FLT3 inhibitor, as I mentioned earlier, there was significant rates of nausea and diarrhea, prompting intervention of both antiemetics and antidiarrheals while on therapy. So pacritinib was approved to treat a myelofibrosis, shrink spleens, improve symptoms in patients who were thrombocytopenic. But a story began to emerge that patients, particularly in PERSIST-2, had not only stabilization of their hemoglobin, but actual improvements. And there were observations that patients became transfusion independent on that trial. And this happened at the same time that ACVR1 inhibition was brought into attention by the development of momelotinib. So going back and looking at the PERSIST-2 trial, Dr. O and colleagues really tried to define how many patients became transfusion independent over the course of the study, and that happened to be 37% of the patients who were transfusion dependent, and also confirmed in lab assays that pacritinib inhibits ACVR1 and decreasing hepcidin production in vitro, thus leading to these improvements in anemia. So not only does pacritinib work in patients who are thrombocytopenic through IRAK1 inhibition, but it also works to improve cytopenias through ACVR1 inhibition. So kind of a 2-for-1 there, if you will. So we begin to develop the story of how does pacritinib work in myelofibrosis? Well, of course, it's a JAK2 inhibitor, which can help treat the spleen and the symptoms associated with the disease, sparing JAK1, hopefully allowing those blood counts not to be suppressed as much as if it were a JAK1, JAK2 inhibitor. But it also inhibits IRAK, which is, again, important in the myelodysplastic features of the disease, as well as ACVR1, which lowers hepcidin levels, alleviating the anemia of inflammatory block. So if we return to our case, let's say we keep the case the same. A 58-year-old male with newly diagnosed primary myelofibrosis, bone marrow biopsy looks the same, mutation profile is the same, but now the hemoglobin is 8.2. If I were to put a patient like this on ruxolitinib, it would most guaranteedly drop them into a range where they would need transfusions. And we would, of course, like to avoid transfusions for a large number of reasons. Obviously, the risk innate with transfusions being transfusion reactions, as well as the risk for iron overload over time, as well as just the decrease in quality of life and burden put on the patients with getting transfusions. Taking a step back and looking at systems-based approach, transfusions are costly. Transfusions are a limited resource. I don't know about you, but I get called by the Red Cross seemingly every day to donate more blood. So definitely we want to be good stewards of that limited resource. And then enter momelotinib. So momelotinib was approved to treat patients who have myelofibrosis, intermediate 2 or high-risk myelofibrosis, who also have anemia. There were 3 large randomized phase 3 trials done with momelotinib, the first being Simplify-1 and the second being Simplify-2. Simplify-1 was the classic oncology trial that you always want to see. Drug A versus drug B. What's better, right? So Simplify-1 was a randomized phase 3 trial comparing momelotinib versus ruxolitinib in previously untreated patients. The results were kind of mixed, though. So momelotinib was not inferior to ruxolitinib in terms of spleen volume response, but was inferior to ruxolitinib in terms of symptom burden improvement. But the thing that kind of emerged in a secondary analysis is that more patients were transfusion independent on momelotinib than on ruxolitinib in the trial. In Simplify-2, momelotinib was compared to best available therapy in patients who were previously treated with ruxolitinib. In that study, SVR35 was not superior to best available therapy when looking at momelotinib. And this was largely due to thought that there was no washout period. So say someone was on ruxolitinib on day 0, they would take the ruxolitinib. On day 1, they would take the momelotinib. There was no chance for, if there was a partial response from the ruxolitinib, for the spleen to grow back to its baseline. So that probably obscured the results for the SVR35 here. But it was superior to best available therapy in terms of symptom improvement. But again, transfusion independence rates were much better for momelotinib than best available therapy. And that led to this phase 2 trial being done, where specifically patients who were transfusion dependent were given momelotinib in an open label fashion. In the study, 2 things were shown. One is that 41% of these patients became transfusion independent. So all these patients were transfusion dependent, then 41% of them became transfusion independent on momelotinib. Secondly, the biologic correlates were done showing that momelotinib, through inhibition of ACVR1, lowers hepcidin levels, thus making iron available for erythropoiesis, really kind of showing that mechanism in full. And this was the basis then for the Momentum trial, which is a prospective randomized trial comparing momelotinib versus danazol in patients who had received prior JAK inhibitors, had intermediate 2 or high-risk disease, who were also anemic, had a hemoglobin less than 10 at least. And momelotinib was compared against danazol because danazol is an active drug at treating anemia in myelofibrosis. So compared to danazol, momelotinib was better at reducing symptoms and certainly better than danazol at reducing spleens, but was not inferior in terms of the number of patients who were transfusion independent at week 24. So in effect, you could say, well, it's a 2-for-1, right? We are treating spleens and symptoms as well as addressing the needs that come along with anemia for this particular drug. Now that we have 4 JAK inhibitors approved, I think really the challenge here is which one do we pick? Because there are no direct comparisons. Really, the only direct comparison that we have is that Simplify-1 trial, which was a prospective randomized trial comparing Rux versus momelotinib in that frontline setting. Yeah, we can look at subsets of patients in Persist-2, but really there's not a lot of other data out there. So for those of us who put together opinion papers or guidelines, it's kind of difficult to sort out which one to use where. So we come up with figures like this that are somewhat vague. I think ruxolitinib is still a great drug to shrink spleens and improve symptoms in patients with myelofibrosis. No drug has been shown to be better at reducing symptom burden in large part. Even with phase 3 add-on studies, we're still seeing ruxolitinib shine in reducing symptoms. And clearly there's a need as well as efficacy for pacritinib in patients with platelet counts less than 50,000. And momelotinib has demonstrated its value in patients who are anemic. And fedratinib has demonstrated value in the second-line setting after ruxolitinib. So we can kind of see bins here where these drugs can be most effective and how you would pick one, both in the frontline setting and in sequence. But really where we're all going with this is using JAK inhibitors as a backbone for combination therapy. Myelofibrosis is not a one-hit wonder. It's not like CML where we give imatinib and patients go into molecular remissions and are effectively cured by taking a pill. There are other pathways that are massively dysregulated in these diseases, and we really need to start to use combination therapies to hit a number of ways that these diseases progress and grow and affect patients in order to get better and better outcomes. A lot of these pathways involve other pathways that are targeted in oncology medicine. Navitoclax may sound familiar to you, BCL2, BCLX, XL inhibitor, because it's a lot like venetoclax, a drug that's used for CLL and AML. We're also focused on targeting the PI3 kinase pathway, whether we're talking about PI3 kinase directly or downstream the MDM2, which is a downregulator of P53. We're looking also to block TGF-beta in various ways, as well as telomerase inhibitors like imetelstat, which was just approved to treat anemia in myelodysplastic syndromes, amongst other drugs. And really kind of the lead studies that are ongoing right now, one is a trial with imetelstat, and this is versus best available therapy in higher risk patients. And the thing that I really like about this trial, it's going for an overall survival advantage. So is imetelstat better than best available therapy for survival? So it's really kind of getting at that underlying disease modification that we're all yearning for. There's an ongoing phase 3 trial looking at luspatercept, which can improve anemia in patients with myelofibrosis, and was shown in a phase 2 trial to really kind of look for that label expansion there to help treat anemia associated with myelofibrosis. Both navitoclax and pelabresib had phase 2 trials in combination with ruxolitinib, where the results were reported at this past year's ASH annual meeting and were positive results for the primary endpoint of spleen volume reduction of at least 35%. These both kind of missed on some of the key secondary endpoints of symptom burden. But if you start to get into the weeds of things with the symptom burden, really fatigue was a major driver of the lack of difference seen, and did not account for baseline fatigue just in the general population. So I think if we kind of really sit down and think about some of these endpoints, I think these endpoints that we have for a lot of these clinical trials may limit our ability to get new drugs for our patients. There's also an ongoing trial with selinexor, which is a cell export inhibitor already approved for myelofibrosis, but has shown early activity in myelofibrosis. So there's a couple of large ongoing trials with selinexor that we all have our eyes on. So our third learning objective for today: develop an individualized strategies to reduce treatment toxicity and enhance treatment adherence for patients with myelofibrosis. So as mentioned earlier, myelofibrosis is a disease of symptoms. We're talking about early satiety, night sweats, fevers, itchy skin, and the lot. And so one way to address this, or at least have a conversation around it, is to take inventory. So this is the MPN-10, also known as the MPN-SAF TSS, where on a scale of 0 to 10, we ask a patient, in the last week, how bad were your night sweats on a scale of 0 to 10? How bad was the itching on a scale of 0 to 10? And so on and so forth. With this, you get a score. You can measure the amount of symptoms that a patient may be having. That way, visit over visit, treatment over treatment, you can tell, are they getting better or are they getting worse? Sometimes the changes in their symptoms may be so subtle a patient may not notice visit to visit to visit. And this way we can kind of catalog how an individual is doing and begin the conversation. Well, what symptoms are you having? What do we need to address? What might be due to myelofibrosis and what may not be due to myelofibrosis? There are online tools to measure MPN-SAF. There are even a few apps that patients can use to track their symptoms daily, all available for free. So patient-reported outcomes are a big focus in not just oncology medicine, but medicine trials in general. And certainly we're thinking more and more about how these symptoms impact patients' quality of life. So symptoms and quality of life are both PROs, patient-reported outcomes, but they actually are measuring somewhat different things. But again, myelofibrosis is a disease of symptoms, so we're intently focused on measuring symptom burden for patients. That's shown here. So the thing I really want to drive home from these figures is the fact that fatigue is so incredibly common and is the most common symptom reported in myelofibrosis, as well as ET and PV, to be honest. And it is often the most severe, where we're seeing the largest number of patients reporting severe scores. The challenge with fatigue, though, it is generally multifactorial. There is an axis of not only disease and therapy, but emotional, as well as other medical problems that can all kind of swirl together to lead to someone's fatigue. And really, it takes a lot of work to separate out all the different causes of fatigue and try to address them individually. Because only addressing the small part that's maybe due to cytokine elevation from their myelofibrosis will only get you part of the way there. But at the end of the day, fatigue is very common and reported to be one of the most severe symptoms that patients face. And again, it can be very dissatisfying when you treat someone's anemia and they just don't feel better, because it isn't the whole story for most patients. So in the landmark study here, shown in the boxes below, done by Dr. Ritchie and colleagues, 81% of patients with myelofibrosis either somewhat agreed or strongly agreed with my MPN symptoms reduce my quality of life. And not only do we see this in studies like this, but we also see it in the clinical trials done with, say, ruxolitinib, where the reverse happened, where symptoms improved and thusly quality of life improved. So although they are measuring different things, they are intrinsically linked. So addressing symptoms can improve quality of life. And by thinking about quality of life overall, it can focuses on treating the symptoms. Again, as I mentioned earlier, it's very helpful to make assessing symptoms part of your workflow. Personally, in my clinic, every visit I have with the patient, I'm running through those 10 questions. What's your fatigue like on a scale of 0 to 10? Your night sweats, your fevers, your itchy skin, every symptom, asking the patient about. A lot of other clinics have initiated like an automated process where a patient fills out the survey for the MPN 10 prior to being seen, either on an iPad or a piece of paper. Then that can be kind of cataloged in the medical record as well. Again, circling back to the JAK inhibitors, because again, symptoms are central. We want to initiate therapy. These therapies can make patients feel better. They can shrink their spleens, improve their symptoms, but they're also go hand in hand with potential side effects. So we always want to be addressing that for any given individual. Okay, what are your symptoms? Will some of your symptoms actually be made worse, or will we introduce other problems if we start one of these JAK inhibitors? For example, if you practice in the sunny South, where there's a lot of chronic skin damage, using a medicine like ruxolitinib might be a little bit more worrisome because of the risk of non-melanoma skin cancers. You may be accelerating some of the actinic keratoses and other features that the person might have on their skin. If you have someone who's already quite malnourished, you may want to hold off fedratinib because it could potentiate a Wernicke's encephalopathy. And really, you want to marry what the patient is feeling, what the potential treatment options are, with everything else going on for them. Again, JAK inhibitors are not perfect. They all have their shortcomings, and we really think about this in three major bins: toxicity, where they're having a side effect that no longer allows them to take the medication; lack of efficacy, where it never worked in the first place or stopped working after it worked initially; as well as this whole idea of disease progression, which could be worsening blood counts, progression to accelerated or blast phase disease, worsening symptoms, or increasing spleen size despite adequate therapy. So learning objective number 4, evaluate the current health disparities impacting treatment outcomes in myelofibrosis, including consideration of clinical trial participation opportunities for patients in underserved populations. So that's a mouthful and certainly a difficult thing, but goes part and part with caring for any patient with an oncologic diagnosis. And most care of oncologic diagnoses is done outside of academic centers. Well over 2/3 of patients that have cancer are cared for by local and regional facilities. So only a quarter to a third of patients are actually going to academic centers where they may have more access to clinical trials. This is for a lot of reasons. One is just transportation issues or different distance they may live from a specialty center. It may be they're so deconditioned that just getting in the car is very difficult, and driving a distance is very difficult. Sometimes it is access. Some centers, it's the wait list to get in is very, very long, and it's difficult to get patients in, even though when we really want to. So there are certainly barriers to getting that nice centered care delivered. But certainly quality care can be delivered in any setting where these patients go to. And really, if we really think about the treatment goal and we think about the information that needs to be exchanged between both the treatment team and the patient and their family, and really kind of bringing all this together to have a shared decision-making model, really putting the patient at the center and saying, well, what are your goals for treatment? What are the therapies available? How do these therapies available best address the goals for your treatment going forward? Kind of a unique piece of treating myelofibrosis is the fact that these drugs are all distributed by specialty pharmacies, which can limit access to these medications. So whenever I prescribe a JAK inhibitor, there's always the hurdles we have to go through: prior authorization, appeals, justification for prescribing, and it doesn't go to this pharmacy, it goes to that specialty pharmacy, which really can be a mounting challenge and limit therapy. And then, of course, you spend months trying to get this drug for this patient. They finally get it, and then they have a side effect, and so you have to repeat all that. So that can really be a challenge. I think that is something that we as a healthcare community really need to start to address, because patients need access to these medications. These medications relieve symptoms, translate into better survival and better quality of life for these patients. So, I think it's something that we need to continue to work on to make our patients' lives better. Again, part of this is continuing conversations and having really good conversations between the healthcare team and the patient. You want to be honest with the patient. You want to set up some time and say, hey, look, here's the treatment landscape. Here's what we're going to do. And really open up those lines of communication. Will this work? How does this fit with everything? Do all your family members know what's going on? Do they need to be educated as well to provide you that support network? So it takes a lot of work. And again, you want to recognize that work that has to go into caring for these patients. It's a lot. And forming that bond with your patients can be so incredibly therapeutic aside of any medication that you may give. So again, can't overemphasize enough developing those relationships as you make this shared decision to go forward with treatment. Here's a nice figure about patients and caregivers as partners in care. I always love it when family members come to visits. It's an extra set of eyes, extra set of ears when we're talking about things. I remember being quoted to me as a trainee, this really old study, which I've yet to find, but the crux of it was, patients retain about 5% of what their doctor tells them during the doctor visit. And I absolutely believe that. So having an extra set of eyes and ears, even at the visits alone, can be incredibly helpful. A family member may hear things slightly different in a different way than a patient may. And putting all that together probably gets us closer to the truth and continuing accurate and open communication. Lay caregivers can also not only give that support and reinforcement of the themes being discussed at the visit, but help with the logistics, right? Getting patients to visits, making sure they're taking their medicine, making sure they're getting enough adequate physical activity and nutrition in, and really kind of help complete the picture. So caregiver partners are so incredibly important in the not only the care of patients with myelofibrosis, but any patient that may come to your clinic for cancer care. But at the middle, we're always putting the patient, right? So what are the goals? What are the resources? How can we use the tools that we have in hand to best achieve those goals? The treatment of myelofibrosis, as many disease, is a multidisciplinary approach. And this figure here kind of illustrates how many people we need to pull in to take care of these patients. Not only the medical oncologist prescribing the medications or monitoring disease, but psychologists to deal with the psychosocial burden of disease, dietitians to address nutrition, pharmacists to help get the drugs to the patient and make sure there's no interactions. The transplant team will float in there, and patients who are transplant eligible, and many others. It really takes a village to take care of these patients. We often think about multidisciplinary teams in the context of, like, say, lung cancer, where there's a surgeon, a medical oncologist, and a radiation oncologist. But really, myelofibrosis, in a very similar fashion, is a multidisciplinary team enacted to take care of these patients. Living with myelofibrosis can certainly be challenging. Finding resources can be difficult. It's a rare disease. By the NIH definition, it is a rare disease. So NIH defines, and NORD does as well, defines a rare disease as less than 200,000 patients in the United States living with that disease, and myelofibrosis is well below that mark. So it's not like hypertension or diabetes where they can just go to the grocery store and see like a dozen people walking around with the same process going on in them. So it can be somewhat isolating. So a lot of folks do turn to resources on the internet, such as Facebook and Facebook groups, as well as patient advocacy groups to kind of get that connection. One, to get information, what are other people going through, but having that kind of common and shared experience. And here's a list of places that patients can go to get good, reliable information and connect with others in the disease space, whether we're talking about the MPN Research Foundation or MPN Advocacy and Education International, which I've both worked with personally. But there are other resources like MPN Voice and MPN Hub, and again, the MPN Forum Facebook group, all with different things to offer for our patients with myelofibrosis. Whenever I think about goals for treatment, or honestly for anything in life, we can always apply the acronym SMART. So specific goals, measurable goals, achievable goals, relevant goals, and time-limited goals. And if we kind of use that framework to talk to a patient, okay, here we got your disease, you're having significant symptoms and a large spleen. We're going to use ruxolitinib. We're going to measure that response over the next 3 to 6 months to make sure we are not just kind of wandering blindly off down a path, that we change if we need to. And of course, this is relevant because improving your spleen symptoms can improve your quality of life and potentially your quantity of life as well. And these are very achievable goals in terms of this treatment, right? We know that roughly a third to almost 40% of patients will have significant spleen volumes and symptom burden improvements on ruxolitinib. So kind of using this SMART framework to discuss those goals with your patient can be a very helpful tool to use. All right, well, thank you so much for your time today. It's been a pleasure to speak with all of you. As you can tell, I'm very passionate about the care of patients with myelofibrosis, and I'm always happy to share my perspectives. So again, thank you very much for spending the time with me.